The genetic side of things is very specialized. And you know this personally, talking with a genetic counselor, there's a lot of information that they have that they give that is over the head of any, general practitioner, even specialist. So that is something that is occurring more, that is at the forefront of medicine, that is continuing to evolve. And I think that we will end up seeing a lot more diagnosis driven by the genetic testing that we're able to do. It's already happening.
Okay, here we go. I love doing interviews with people that I love and also that I talk to almost, I feel like a lot. So it's really easy and will be. Carley Cassity, a registered nurse practitioner. I think of you and the words holistic, homeopathic, preventive medicine all come to mind. I think I've done a lot of interviews with different doctors and nurses who really focus on the whole body and approaching the whole body, particularly in our case, women, as one whole being and really trying to get to the root cause and figure out how can we identify the root cause and then treat that as opposed to treating the symptoms, which is to me kind of the definition of preventive care in many ways. Mm-hmm. So will you just give us a little background and tell us how and why you came into taking this approach to your practice?
I would say that I've always practiced a little bit more preventatively in my own healthcare through life. And some of that was, I think, related to just influences throughout life. I had a best friend when I was young, and she had very severe asthma, and her mother sort of found her way to homeopathic medicine as a last resort, or I should say integrative, maybe more so. And then was married in my early 20s, and that person's family was connected to more integrative preventative care. And so I had some influence there with regard to different homeopathic treatments and approach. And so as things came up for myself in my own health through life, it just tended to be the direction that I took in trying to figure out what was going on at various points in my early 20s. And so when I went into medicine, I just gravitated more toward that naturally because I'd already been practicing that as a layperson. I didn't become a nurse practitioner until I was a little bit older. I went back to school at 28. And so I had a little life that I had lived at that point. And quite honestly, it just makes sense, right? I mean, being more preventative and proactive as opposed to reactive is really the way that medicine, in my opinion, should be. And so that's really where it comes from.
And how do you think you're not 28 anymore? But how do you see your experiences and your clinical practice, and how has that even changed the way you look at people, their issues even more? Like now, after you decided to go down that road, now you've been down that road for a few years, not that many, but how has that sort of experience changed and shaped the way that you do your job?
You also have to meet a patient where they are. So I went to school in Kentucky, in Louisville, Kentucky, and the patient population there is much different than Los Angeles, California, as you can imagine, in good ways and bad ways, right? It's different everywhere that you go, different cultures, different takes on what they see as self-care and healthcare. And so, I had a wonderful preceptor there. He was a family medicine physician. And one of the things that he said to me was a physical assessment and an intake assessment is the most important thing that you have as a tool and as a skill. And I find that he's absolutely correct, and that is something that I have maintained throughout practice and tried to hone a little bit, probably more during practice. You can find out a lot and you can diagnose a lot just based on what a person is telling you. So really listening well and listening properly sometimes is a much better tool than any diagnostic tool, any lab test. And so I would say that in the beginning, when you're new in practice, you're looking for these diagnostic tests and tools to try to tell you what it might be that is going on for a person. And as you do it a little bit longer, you realize, oh, I really just need to be listening a little bit better. That came up, right, in something that they said in the assessment. And then the diagnostic tools and tests can inform your hypothesis and maybe rule some things out or rule some things in. But I think that, in my opinion, a good clinician gets better over time with better listening assessment and some physical assessment in there.
And sadly, so few doctors and practitioners do that. It should be the standard and the norm, but I feel like people tend to go straight to the tests and not sit back and like really listen and understand, try to understand. And then I think also you have this wonderful ability to ask the right questions, which I'm assuming you've also honed over time, just sort of probe into maybe that's I feel like something peaks in you and then you're like, I think I'm going to ask a little more about that because I feel like that might lead us down the road we want to go towards. Am I making that up or do you feel that way?
Yeah, no, that's correct. I think medicine is like detective work in some way. So you're listening, you're forming a hypothesis along the way, something that you might have a few, right? We call them differential diagnosis that you might be thinking, oh, this is the top hypothesis that I have, but there might be 4 more differential diagnoses that it could be, and then you're focusing your questions based upon that. And you're also focusing your testing based upon that to rule something out or to rule something in, not just, and this I should say in functional medicine is also important. And I would say Western medicine harps on this a little bit, that you're not just doing all of the broad testing that can be done, doing a stool test on every single person or a hormone test on every single person, but really allowing the assessment to inform your clinical judgment. In the testing to rule things out or rule things in. And I would say you're correct. I mean, the lack of listening, I think, comes from where we are in medicine and what the time constraints are on traditional insurance paid Western medicine doctors. It's not that those clinicians don't want to listen. They just don't have the time to listen, right? They have 15 to 30 minutes depending on the intake. And so they're limited, sadly.
Yeah. I get it. Like I totally get it. And in order for it to change, the system has to change from the inside out. But you really, as a patient, you don't fully get the difference and understand it until you're with someone like you who spends so much time. I also think it's I was thinking about this the other day, like one of the greatest things to come out of COVID, telehealth. And really what that has done, I hope, for both sides, the patient and the clinician, is saying so much of this is actually talking and listening. And I don't need to poke and prod you because what you're going to tell me, if we go down the right roads and I ask the right questions and really get you to be open and honest and transparent about what's happening, you can find out a lot. Isn't that? I think it's like one of the great things to come out of a period where you didn't go see your doctor. And it was almost revolutionary. And maybe like it was such a new technology being used, but actually sent us back to the basics.
I agree. Absolutely. I agree. Yeah. And opened up care for people that didn't have access to care, definitely didn't have access to specific types of care, because before telehealth, you were limited to where you lived and who was local around you there or where you could travel to. Right. So, absolutely.
I think it's one of those great things. And I hope helps make that change from inside out. Like, I hope it's this new way of this addition of being able to talk to people who are licensed all over the country from anywhere teaches all of us that really spending those minutes, and even if it's 15 minutes, if it's 15 good minutes where you're just really getting into it before you order the tests, before you say, okay, now you need to say someone local and do these things, it's very substantial, and it can be. I've been thinking about that a lot because I I don't know why I have, but I maybe because a lot of the doctors that I see aren't a drive for me. I do
Mhm.
a lot of it on face-to-face Zooms because so much of it is clinical. So let's do a pretend case. Wink, wink. So a woman comes in to see you. She's, almost 50 and has suffered from migraines for a very long time, but they're like awful. Like they've gone cuckoo bananas, just terrible. And a lot of the sort of normal perimenopausal things are happening where you're like, she's up in the middle of the night. She thinks maybe that makes her cortisol race, but doesn't know. She's not just up in the middle of the night, up in the middle of the night having like anxiety, major anxiety about things she's
Mhm.
never been anxious before. And also her body feels like just like different. Like it's like someone else's body is all of a sudden overnight taken over hers. Where do you start? What kind of questions do you ask? Like, how do you deal with that patient?
That patient, I would say, is maybe slightly easier just because with the age and with the sex comes a little bit of knowledge about
Yeah.
where she is in her time of life and kind of what
Yeah.
to expect. But you can't rule things out completely like, is this something neurologic that may need to be
Hmm.
assessed? So when I talk about differential diagnosis, it's just something that you keep in mind, that you're not saying, oh,
Yeah.
this has to be hormones, and completely, forgetting that. So I would ask other things, looking more into the headaches and the migraines as well. Like, is there any aura that comes on before, which can be
Hmm.
visual if it's more neurologic? If there's any more sort of neurologic symptoms that might be occurring, like dizziness or any kind of eyesight issues that might be happening. So you have to look at that side of things also. But again, given her presentation of age and sex, and that's a very menopausal
Yeah.
symptom. It's something that I feel comfortable enough because I treat so many menopausal, perimenopausal females and postmenopausal females that that's one of the areas that I would go directly to. And so furthering questions like you had brought up as far as other types of symptoms, waking up in the middle of the night, the anxiety, are there any night sweats? Are there any hot flashes that are going on? Skin changes that might be occurring, dryness,
Hmm.
vaginal dryness,
Hmm.
mood shifts, obviously, irritability, lack of libido, a drop in libido. So those are just the questions, right, in the intake. And then the obvious things like, well, when was your last menstrual period? Are you still menstruating? And taking all of that into consideration. If a female is no longer menstruating, well, you can, definitively say that she's, as long as it's been a full 12 months, that she's in menopause at that point. And so fairly obvious. The perimenopausal females, where they're still in that in between, tend to be a little bit more tricky. So those would be more of the questions that I would ask. There's not a whole lot of physical hands on as far as a physical assessment for a
Yeah.
menopausal or perimenopausal female that needs to be done. Now, if you're trying to rule out neurologic, then you would be doing more of a physical exam and looking at pupils and making sure that dilation is normal and gait and watching them walk and all of that. And so then the labs would come. That's where this is also interesting when you talk about a menopausal or perimenopausal female, is that not all clinicians will draw blood work and look at the hormones on that patient. And that's technically an okay thing to do. Again, if you're listening to the symptoms and the symptom resolution are going to be what drives your treatment much more than
Hmm.
a number on a
Hmm.
piece of paper. So if I draw an
Hmm.
estradiol number and it looks like it's, say, 55, which can be very normal for some females and normal and have no symptoms, not in menopause, right? Normal through their menstruating life. It also varies depending on the time frame of the cycle, but some women will feel okay with that level and other women will not feel okay with that level. I don't treat to a number. So if I'm treating with estrogen replacement or hormone replacement therapy, I'm not treating to that number getting to a certain place. I'm treating to where the symptoms are. So
Right.
you can look at labs, and I happen to like the data of that because I track that along the way, and it just gives me a little bit more of a dialed in understanding of where that female might be versus another female, because numbers can be completely different. But I know plenty of clinicians who don't look at labs. And again, that's okay, especially if you know that she's already menopausal fully.
Yeah. And those labs are, to me, they're a snapshot in time because they're so fluctuating. But if you're following up with more labs and keep checking in and having that data set, I understand that. Like that makes sense to me for sure.
Yeah. 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 Ongoing reassessment is very necessary. And so
Yeah.
it's one more data point to inform you about treatment and about symptom resolution. And so I like that data. So I do those labs.
So a lot of women talk about, and it's obviously like a hot button topic. And I've talked about it with a lot of other people. And I want to hear your take on either for this particular woman that we've been talking about or anyone. What are your thoughts on peptides? And obviously one of them being GLP-1. And so what are your thoughts? And do you use them? How do you prescribe them? Do you like them? What's your thoughts?
Easy answer to that is yes, I use them and I love them. Are they for everyone? No, they're not. So as is every treatment, hormone replacement therapy is not for every woman. You have to look at medical history and family genetic history in factoring all of that information in and making a clinical decision and assessment as far as a plan of care. So GLP-1s are wonderful, obviously, for the weight loss, right? They're giving a lot of patients a tool that they did not have. And these are particular patients who were unable to lose weight throughout their life, struggled with weight loss, have done everything that has come along the way, all medications, all types of diets, all programs, and have yo-yoed back and forth or never been able to lose the weight that they needed to lose. GLP-1 agonists are therefore a wonderful tool for those patients. And I have seen them to be life-changing for patients, absolutely life-changing. They also have other benefits to them. Now they're being studied for cognitive improvement or prevention of cognitive decline. And there's some other studies that are going on. But I would say just in what I see anecdotally in practice is they reduce inflammation. A lot of patients will feel better energy with them, sleep better. A lot of perimenopausal women will have their symptoms resolve or be relieved significantly with the use of those. And so they have other broad implications to them, not just the weight loss. And for that reason is why I say I think that they're phenomenal. Again, for everyone, no, you need to take that into consideration when you're creating a care plan for a person and a patient. But they are wonderful. I would say the subset of patients that I see do particularly well with them is the autoimmune condition patients with chronic inflammation. I have some MS patients. I have some fibromyalgia patients. Those patients have life changing effects because of the reduction in inflammation that they see. And we now are microdosing them, GLP-1 agonists. And it is for that anti-inflammatory impact, not necessarily for the weight loss side of things as well. And so if you dose appropriately and you microdose patients, you can get that anti-inflammatory effect without seeing the weight loss.
And what are your thoughts on, I've talked to so many women who are my age, this almost 50, all of a sudden there's just this like 5 to 8 pounds that's just like there and like is not going to go away. Would you recommend a very small dose of a GLP-1 for that, or say kind of is what it is?
I commonly do utilize a microdose in that patient population, but I also first make sure that I'm assessing where's your diet, where's your exercise routine, what's going on because that's foundational. And so if they're not doing the foundational things, I really hesitate to put someone on something that in their mind is just this quick fix, because I also worry that they won't do the foundational things that they need to. And some of the concern with GLP-1 usage, which I actually don't see with microdosing, but it's still something to consider, is that there's some muscle loss that can happen. You have to really coach a patient and be very mindful about the protein intake in that patient population, that menopausal female. You really need to be incorporating weight-bearing activity for bone density regardless, but you want that person to be doing weightlifting because you want to maintain their muscle mass at the same time. So yes, I often do with those patients in a microdose and see phenomenal results. And they have all of those other benefits that I talked about and feel better with reduction of inflammation. But I just make sure that I assess all of that first. And then the follow-up too, because
Totally.
I've done both things. I've put a person on them and said, here you go. I think you're good. And this is just, I'll just tell you, this is me talking about how you treat and learning myself in some ways that I do things that I have found that are not the greatest is you sometimes have to make sure that you bring a person back to say, are you doing that? Are you following the instructions? Because otherwise you don't want to see them waste away and not be as healthy as they should be.
And I mean, a lot of people talk about microdosing a GLP-1. What is that? What's the dosage? What does that mean?
So it depends on which medication you're using. So the medication names, and there's the name brands, and then there's the medication name, right? So semaglutide is the same as Ozempic and Wegovy in the brand name. Wegovy for weight loss, Ozempic for diabetes. And then tirzepatide is the medication name, and that is Zepbound and Mounjaro. And Zepbound is for weight loss, Mounjaro for diabetes. So dosing for semaglutide starts at 0.25 milligrams. And so a microdose would be something like a 0.10 or a 0.15, half or even a quarter of the actual starting dose. And sometimes people need to work their way up a little, but I always start under the starting dose. And then tirzepatide, the starting dose is 2.5. And so same thing. I'll often start a person in units, it would be different, but at a 1.5 or a 1.0 milligram dose.
And then some of these new drugs I've heard about, like particularly the Wegovy pill, in order for it to work, you work your way up. So I just talked to this gal the other day, she's like, well, I'm going to start at 0.25 and just stay on that. Because she was like, I just want to lose. She was, in this camp that we're talking about. She was like, I just want to lose 6-7 pounds, and doing all the right things. She works out properly, eats, blah blah blah. What does that mean? And I was like, she's asking my opinion. I'm like, I have no idea. I'm like, I'm not an expert in this. Don't ask me.
So the oral medication for semaglutide is not new. Rybelsus came out from the company and the maker of semaglutide, Ozempic, and Wegovy years ago.
Yeah.
What I found with that medication, and the Wegovy pill is a little bit different, right? It just was released this year. So it's new and they reformulated.
Like 3 weeks new.
Yeah, very new. So I have not used a lot of the oral Wegovy. And that's only just because of the newness of it. Also, I'm on maternity leave right now, so I haven't been treating recently. But I found that with Rybelsus, it was good for maintaining. It was not as good as the injectables for the weight loss. So it was better for maintaining weight when a person got to the goal that they wanted to be. Not to say that some patients didn't lose, but if I had a cohort of 100 patients that I was looking at, very few of them would actually lose the weight on the pill. The Wegovy pill may be completely different. To answer that a little bit more appropriately is to say that every patient is very different from what I have found on the injectables. And so some patients I will microdose and they will lose the 6 to 10 pounds that they need and they never change the dose. And they were doing the right things and they were exercising and eating properly. And other patients have to go up and sometimes up to the highest dose. And it's just there's genetics at play there. A lot of genetics. Age plays a major role. So that menopausal female or perimenopausal female is almost like a point against her in some of the ways with regard to metabolism. When I'm assessing that picture, sometimes I know that she's probably not going to stay on that lowest dose. But again, every person is different. So it's really a matter of assessing and then reassessing and checking back again in 3 weeks. What weight loss have you noticed? What are you feeling? What are the symptoms? Some patients will not see the weight loss, but can't tolerate the side effects. So that's a little bit tricky too. Can you go up in the dosing as you need to? But so it depends on her, very specific to her.
Yeah. So let's switch gears a minute because my other favorite topic is the gut, which I have talked to you many times about. Personal kids in my family and just in general. And so, you have someone come in and present just sort of clear gut issues ranging, just like things are not working properly. How do you start? Obviously you talk and you ask, but what in your back of your mind are you thinking about when someone's coming in and they vomit or they have diarrhea unusually, or they, have reflux since forever, or there's just insane gas, or, there's something off. Like, what are you thinking in your head while you're asking the questions?
Time frame and history of presentation are key there, because if it was more acute, what's been going on in that more acute phase versus has it been more chronic? And if that's the case, has it been decades that it's been going on? And so we have to kind of then look back and say, a lot of times when patients are giving their medical history, they may not go back 10, 20 years. But if
Right.
it's been a chronic issue, you really have to look at, well, what was your antibiotic use maybe as a child, if they're an adult at this point? What was your diet like back then? Because that can really change the gut over time. GI is a little bit trickier. It's not so straightforward. It truly is. And so you really have to dial in a little bit more to some of those key factors and asking more directed, prompted questions about, when did it start, precipitating factors? Is there a stress component to this, a travel component to this? Is it more IBS and IBD versus something like SIBO and small intestinal bacterial overgrowth? And so I would say that's sort of what's happening, is maybe a bit more questioning and prior history questioning. And then you can go into some of the testing with stool testing and SIBO breath testing.
Talk to us about antibiotic use and the upsides and downsides. I feel like it's a hot button topic, and I'm not asking that in a political, and I'm not asking a vaccine way and anti whatever. I'm asking that, like, truly, I think a lot of people don't know that for every action, there's an opposite and equal reaction. And
That's
for
a good point.
every Advil, Aleve, Tylenol, whatever antibiotic you take, there's some reaction that's going to happen, and hoping it's good. But there's something else happening too. Will you just dive into that a little bit? Because I think it's really fascinating, and I don't think very many people talk about it.
Yeah, that's a great point. I think that you have to bring that up in medicine, period, right? Even when we're talking about GLP-1s, for instance, are there zero side effects? No. So, I mean, antibiotics are amazing. We are where we are as a human race because antibiotics have saved us from diseases. Modern medicine is what it is. A lot of that is because of antibiotic development and use. So, they're wonderful for infections when necessary and when used prudently. It's one thing that you see in primary care setting when you go into medicine is that there is a lot of overuse of antibiotics, and any practitioner would tell you that. And especially more now with Google and AI, because patients come in asking for what they want, and it's not as much a matter of clinical guidance in what
they're going to leave with that
receiving.
prescription, whether you want to give it to them or not. Totally. 100%.
Yeah. Yeah. And so you bring up a very good point in the education side of things. You should be educating a patient with regard to that. Antibiotic resistance is something that you should be talking about with regard to that, and how it affects the gastrointestinal tract is what you're getting at there. And it's true. We have good bacteria called commensal bacteria in our gastrointestinal tract, which we need and we want. And then we have potential pathogenic bacteria that can be there and causing infections. And obviously we don't want those things and have to get rid of those things. But overuse of antibiotics or chronic use consistently can kill off the good commensal bacteria and then give you more issues, maybe even more significant than the thing that you were treating to begin with. And so it is very important to not overuse antibiotics, to get a good history about a person's antibiotic use throughout life. And so that's where small intestinal bacterial overgrowth you see a lot of the time with overuse, sort of chronic overuse. So yeah, good and bad. Same thing with something like a nonsteroidal anti-inflammatory. Chronic use of that is not good for the gastrointestinal tract. And a lot of people don't know that. They truly don't.
Highly educated people don't know that. And there's also this time, I hope for most people, it's like in their 20s, but it goes on and on for lots of other people. You go out, you have a few drinks, you pop a few Advil or Aleve or Tylenol, whatever, and then you go to sleep. And you're like, sweet, I'm not going to wake up with a blasting headache. Then people do that a lot. Without the knowledge that is like ripping the lining of their gut. And for some people, like, everyone's different, as you've said many times. So some people that might not be an issue, but other people, that can create significant long-term issues. And, it's funny, I don't know if it's because we watch sports in my house, but like every commercial is for some medication, and then it's the quick, here are the side effects, diarrhea, vomiting, nausea. But no one talks about those side effects with the things that people take all the time that you readily go into a supermarket, a pharmacy, wherever, and grab off the shelf. And you also make sure you always have them in your house.
That's true. That is true.
That's what we're told. Like as a mom, you're told like, you better make sure you always have non-expired X, Y, and Z in case someone gets a fever, in case someone hurts their leg, like whatever it is. And you kind of dose them out at will. It fascinates me knowing what I know now, for sure. For sure.
Yeah. Just because something is over the counter and readily available doesn't make it completely benign and something that we can just use without regard for long-term use or that's very true. Patient education is also a key topic and something that really should go into a full assessment and a full visit as well. And that just goes across the board for anything that we're talking about, not just medicine, obviously. The more you educate a person, the more tools you give them as well to be in charge of their own health and to take charge of their own health and to really feel empowered to do so. I'm not with a patient every day. So they are a much better clinician if I give them the knowledge about something than I can ever be, because they'll come back and say, oh, you had talked about this and that as symptoms. And, I hadn't really thought about it before, but I am having those things. And so I would say, there's good and bad about everything in life, and Google and the internet and AI, that part of things is very good. Sometimes patients come in much more informed about their own care because they've done some research. Sometimes they also come in thinking that they know what is happening and what is best, but good and bad with everything.
We were in skiing this last weekend. I don't know when I'm going to release this episode, but it was during the huge storm and we got the tail end of it in Colorado. So we, and we had dinner with one of my youngest son's friends' parents. And his friend had the weekend prior taken a bad spill on the mountain and kind of fallen in a way where like he fell forward and like hit his ski and he couldn't breathe. And so it was questionable whether he knocked the wind out of himself or he like punctured or hit something. And so he was, having trouble being, the parents were with him. They, kind of calmed him down. Then they brought him down to the bottom of the mountain. And then the mom said to me, I told him, go in and use ChatGPT and put in all your symptoms and everything you're feeling and we'll know what's wrong with you. And I just giggled, when she's telling me this story. And I'm like the quintessential Jewish mother. Like if that happened to my kid, like we're going straight to the we're going straight to the ER and we're going to figure out if he broke a rib or punctured a lung. Like I'm thinking worst case scenario. But it fascinated me. And these are wonderful people that I'm not putting them down in any way, but that's sort of the first line of defense that most people are using. And so often I think it's fine, like it's sure, whatever. But this sense of like the importance of, and it's like a week later and the kid still is in pain. And I'm like, the sense of like, it's so easy to talk to an expert and ask and just give the list. And it's a different kind of conversation than when you just put it in and get the answers, because it's not a dialogue. And so the dialogue piece gets lost in using the internet and AI to sort of diagnose yourself and figure out what to do. And that kind of breaks my heart a little bit. And we do it in my house, there's a mole or some crazy thing, but I always am like, I now go talk to X, Y, and Z about it and go show them. But it is interesting. And that is one of the, I think, real challenges for patients and people in the medical community to figure out how to deal with the fact that people are using this, knowledge at their fingertips. And how do we respond to that? And how do we figure out how to work with that? Probably not against it.
I agree, because it's a wonderful tool, even on the clinician side of things, right? There's sometimes I have to look things up. I don't know everything. I don't remember everything, right? Yeah. Yeah. And in an emergent situation like that, luckily they have to go through certain avenues and barriers to get maybe the X-ray or a
Yeah.
CT or something, right? It's I would say actually in primary care, people have the ability now to do their own test ordering through
Mhm.
various labs and things.
Yeah.
So in that sense, it's a little bit more not dangerous, but they have this ability to sort of self-diagnose and self-treat.
Yeah.
Thankfully, in an emergency situation, you would have to go to a hospital and get that
Yeah.
order, or go to your primary care and get the order, right? But there are many good things that will come out of this, absolutely, on all fronts, not just medicine. It's just a matter of navigating that along the way.
Yeah.
Yeah.
I mean, it's like, I am a huge advocate of genetic testing, and there's so many genes we can test now. But I always, in tandem, say, please don't do it without a genetic counselor, without a certified registered genetic counselor, because you're going to get a lot of information and you have to go through that with someone who knows what they're talking about. And it's not, to me, it's like, it's not worth it if you don't do that with a professional, by your side, walking you
100%.
through it. And because there's a lot of information and a lot of different choices and avenues to go down with that information. And it's very emotional. And so you're just not as wonderful
Mhm.
and smart and, awesome and proactive as you are. It's not a thing to take on alone. And I feel the same way with all the tools that we're now given without a prescription and without
Yeah.
a doctor's
Yeah.
guidance, and, with us for sure. What are some of the things that are really exciting to you? What are some of the tools that have come out in the last, 10 years that we've talked about telehealth a little bit, things that like, full body scans, like what are things that you really think have become game changers or will become game changers in this field of preventive care and of treating a whole body?
It's interesting that you brought up genetic testing, because I think that is only continuing to evolve more and more.
Mhm.
And we're now
Mhm.
able to test more with regard to genetics and have that inform decision making and diagnosing. And you're 100% correct that the genetic side of things is very specialized. And you
Mhm.
know this personally,
Yeah.
talking with a genetic counselor, there's a lot of information that they have that they give that is over the head of any practitioner, general
Yeah.
practitioner, even specialist. So that is something that is occurring more, that is at the forefront of medicine, that is continuing to evolve. And I think that we will end up seeing a lot more diagnosis driven by the genetic testing that we're
Yeah.
able to do. It's already happening. So that's one thing. Cancer testing is changing a bit. So there's a Gallery, the Grail test, which is a comprehensive test. We use it in our practice. I'm seeing that used more and more, even in traditional Western medicine. Insurance doesn't cover it yet, but that potentially could change soon down the road. But that's a good test. It's not complete. It's not everything. It's not the most sensitive on some cancers and specific on some, but it's just a wonderful test because it's a very easy blood test. It's not that expensive, particularly through the Western medical lens. There is lot of negative response to over testing. And sometimes over testing in functional medicine, they feel like can happen. And so whole body scans, whole body MRI scans, I do not advocate for every patient. Again, I allow the clinical assessment to inform that
Yeah.
decision. But for some patients, it does make sense to do. And so I think it's a good tool to have and to be able to utilize. And now there are companies that are making it more reasonable as far as cost is concerned.
So do it in tandem with you. Like do it in tandem with your doctor. Don't just sign up for a Prenuvo full body scan without, your tag along doctor.
Yes.
Physician.
Yes.
Yeah.
Yes. I
I mean, I
100%.
100% agree. Yeah.
Yeah.
And it's interesting because a lot of the people that I know that have done those have kind of in their head been without a doctor with them. Like have just gone, made the appointment, gone in. It was like a birthday present. but thought, fun, happy birthday, right? So, but they were thinking something else was going to come up, or hoping it wouldn't come up. Like someone who was, and their parents had heart disease or whatever. And then that doesn't come up, but something else completely random does. And so now they've learned they thought they might hopefully not have X, and they find out they have Z, and they are not like prepared because they've, gone out and did it like they were going out to eat lunch. And so that to me is like part of the whole conversation we're having of this, this need to have the clinical pre, during, and post. Otherwise, you're like hanging yourself out there.
Absolutely. And then you're becoming anxious when you receive the results, and nothing good nor bad I want about any of the tests or any of the companies out there doing any of it. I think they're only, helping to just sort of further what's available to us. So I'm not saying anything negative necessarily, but Prenuvo has gotten a little better, I think, in their assessment and connecting with the patient after to give them the full assessment of the findings. In the very beginning, they weren't. They would give the results back and they would say, here, go back to your primary care, go back to see, your
assuming
doctor.
Someone had a primary care doctor.
Right.
Yeah.
Right. So a lot of times I would get patients coming to me and say, here are my results. Can we go over these? And just me being now, some practitioners would say, no, I'm not going to go to the place that you received, that you had this test done. I would go over them, but a lot of times they would come with a lot of anxiety about some of the findings that were actually benign. Yeah. But the way that it's listed on there, you don't know. As a layperson, you don't really know. And then you you put in some stuff into Google or AI and it tells you that you're dying.
I'm literally going to die tomorrow. Yeah, totally. And also this, the blame and shame of like, how did I not know? Or how did this happen? Or how did I allow this to happen? Or you start Googling, if you ate this, you'll get this. And you're like,
right.
Which is a circus, you're signing yourself up for a circus act. Yeah.
Yeah.
Crazy.
So yes, agreed. Having someone that is there along the way to sort of inform whether you should be doing this, should not be doing this, give you the results of everything in the follow-up. Yeah. Is necessary.
Well, we're going to wrap this up, and I'm just going to say, I'm so excited to meet your baby.
Oh, thank you so much.
Thank you for doing this. Pregnant. How are you? 9 months?
No, I delivered.
You delivered?
He's here. Yes.
Wait, what?
Yeah. Yes.
Oh my God.
Yeah, this is maternity leave right now. Yeah, he is.
I thought you were still I thought this was like happening later at the end. Oh my God, I guess it is the end of the month.
Well,
congratulations, Mazel Tov. This is amazing.
Thank you. Yeah, the recovery is something. But
no one tells you about those things. Yeah.
Yep. Even as a practitioner, you think it's actually been pretty good and it's all been pretty amazing.
Yeah, but some of the stuff is icky. There's no question.
Yeah, it's not easy. It's definitely none of it is easy. Yep. So he's here doing well.
Aww.
He's all the things, eating, pooping,
That's all that happens.
That's it.
Eat,
Sleeping.
Poop, and sleep. Yeah.
That's right. Yeah.
Well, enjoy it. Thank you so much for taking time out to do this. I hope he was sleeping the whole time.
I hope he was too. Someone's with him.
Just enjoy every moment, and it goes by too quickly. Thank you so much. And thank you so much, Carley. This is a fabulous, fabulous wealth of information that you've shared with us. And I hope that people take the takeaways that are meant to be, because there's a lot of them in this episode. So thank you so much.
No, thank you for having me. I really appreciate it. I love you so much. And it's always good to talk to you. And no, I'm honored that you asked me. So thank you.